What options do I have?
So I would first start with negotiation. That's the first process. You want to look at that.
Have you heard that term?
Absolutely, yeah. So the most common that we see, and we talk about, is the non-covered services law as well, so too. So
Okay. Can you talk about what the difference is between an NPI 1 and an NPI 2?
sure, NPI 1 is an individual provider's NPI.
What I see, every single day is that the buyers end up billing under the seller's credentials as the treating doctor, meaning the buyer ends up. Hello and welcome back to Ali Off the Record. I'm your host, Ali Rumchian, and today we're joined by Lisa Byers, a dental benefits analyst with the California Dental Association, which is an organization that plays a major role in supporting dentists and advancing the profession throughout California. Now, in her role at the CDA, Lisa works very closely with dentists to help them better understand dental benefit plans, navigating third-party payers, and addressing many of the challenges that come with working with insurance companies. And there's a lot of challenges. Today, we're going to discuss how dental benefits impact practice owners, common issues dentists face with third-party payers, especially those that are buying practices, and what doctors should understand if they want to protect the financial health of their practice. So stick around. You're not going to want to miss this episode. Thanks. Hi, Lisa. Welcome to Ali Off the Record. I'm so excited to have you on.
Thank you. I'm excited to be here. Our first time recording together.
Yeah, it is. And what's funny is I think after HR questions about benefits and third-party payers and all the fun stuff we're going to talk about is probably the second most important or most frequent questions that I get. And I always send them back to you because I'm like, I don't know.
Yeah.
It's just so complicated. It's so complicated. So
Live in the insurance world, you live in the HR world.
That's right. And so, our audience is going to be really, really excited to hear this podcast. So thank you for being here. Can you give a little bit of background on you and what you do at CDA? I know you have 20 years of experience in dentistry, but give the audience sort of a little bit of a background on how you got to where you are right now.
Sure. I started in dentistry. I was actually looking for a job that was a little bit closer to home. My commute that I was doing at the time was pretty significant, and so I found something that was a little bit closer to home. And I was working with some friends of mine. And I tell this story all the time when I do my presentations. Is that when I was younger, we couldn't afford braces. It just was not in the family's financial budget.
Sure.
So when I started working in dental, I actually went to work for an orthodontist office, believe it or not. And I started doing his treatment coordination. And when I would see patients that would come in and their parents, they had dual coverage, I would be so excited for them because I thought this just makes it so affordable for the family. And I was just excited for the kids. They were going to get braces and all of that. And then the longer I started working with dual insurances, a patient would come in, I'd be like, oh, they've got dual coverage because the coordination of benefits can just be such a nightmare. And so it started out like a love of it. And then after a while, I was like, this is a lot of work. So yeah, I started in a private practice orthodontist, worked there for about 8 years. From there, I transitioned into a multi-doctor, multi-location practice, and then was there for about 12 years. Finished up there right before I came to CDA. I was a revenue cycle management for specialist for a huge area. Almost the whole of Northern California had about 70 offices.
Wow.
But yeah, truly, like it was fun because I got to dig into the insurance and the claim denials and do adjustments and things like that. And so that's kind of how it started. It started from that initial love of the dual coordination and it just kind of spread on from there. So
yeah. Revenue cycle management, RCM, for those of you that don't know, is like the key term for like 2025 going into 2026. It seems like there's companies popping up that do this left and right. And now with AI, it's become much more, frequent of a thing. So yeah, that's really, I think, where we should jump into, because we have, as you know, at the firm, a lot of clients who are opening up their office for the first time, or they're buying someone's office. And the question that I always get has to do with like reimbursements and fee schedules. Okay.
Yeah.
So let's jump into that, because how would you advise a dentist to evaluate whether a PPO plan is actually profitable for them? Whether they should, if they're starting out from scratch, whether they should sign up for a PPO plan, or if they're buying a practice, should they stay in it? Like, what are some of the basic things they should be looking at?
It really starts from the business model. As you're starting out, like laying out your business model as far as how you want to practice. There are, everyone usually says like fee for service would be great. We're just going to be a cash office fee for service. We're going to bill as a courtesy, but not every practice and practice owner wants to practice that way. So it really starts with your business model. And then also your staff, how busy do you want to be? Do you want to be in network with a lot of plans and have to manage that and see more patients and all of that? But truly it's not just the fee schedule that we want them to evaluate. There's so many other things that come along when you're contracting with a plan. Of course, you've seen this as well. So too, dive into those contracts and look at those contracts. But the fee schedule is of course a portion of it and it's important. But also the clauses that come along with any of those contracts with the plans and the inclusive procedures and the payment processing guidelines and how the plan is actually going to pay for certain procedures. So we really have them take a look at the fee schedule, look at their overhead, look at the difference between what their overhead is and their UCR of that fee schedule and kind of evaluate, is this sustainable for the long term? But truly, initially the fee schedules is what everybody kind of gets stuck on. I try to open their eyes a little bit wider when I talk about some plans. If you do a buildup on the same day that a crown is prepped, the buildup is inclusive of the crown prep. So not only are you taking a reduction of the fees for the crown, but now whatever fee for the buildup, now the buildup's going to be listed on the fee schedule. There's going to be a dollar amount attached to that. Whatever you would be compensated for that buildup is going to be inclusive of the crown. And I talk about that also too, even when we talk about dentures, initial denture placement, your adjustments, whether it's,
Mm,
an in-office reline or a lab reline in your adjustments are typically inclusive of the initial placement for about 6 months.
yeah.
So it's not just the dollar amount that's attached to the fee schedule, it's all of the other processing guidelines that go along with it. So
Yeah, yeah, that's
getting
such
a
an
good
important
idea.
point. Yeah,
Yeah.
that's such an important point. And do you like when someone comes to you through CDA to look at this fee schedule, walk me through that process. Like, do you advise them, hey, if you're going to open up your new office, come with your business plan. Let's talk through it, and let's talk through what different insurance companies do, or should they apply, get their fee schedules and all the documentation, and then come to you?
We don't have the bandwidth to be able to do that for our members also too. We really try
Got
to
it.
stay away from fee schedules, exact fee schedules for dentists, just because we don't want to teeter on any kind of antitrust issues.
Oh, got it. Okay.
We do have a fantastic resource. It's the Evaluating a Dental Benefit Plan checklist that will help them evaluate potentially going in network with a plan and also if they are potentially looking at going out of network with a plan.
Ah.
But yeah, that Evaluating a Dental Benefit Plan checklist really walks them through the steps. We put a lot of time and effort into getting that resource together. It's the process that a consultant would go through when looking at whether you want to go in network with a plan or out of network with a plan.
I love that. I love that. And
Yeah.
so is that available on the CDA website, I assume?
Yep. It's
Okay.
available on
All right.
cda.org. Yep.
Okay, perfect. Yeah. So if
Yeah.
you're a member of CDA, don't forget there's a ton of resources on the website. I mean, not
So
only
many resources.
yeah, exactly. I mean, we always talk about the HR manuals and stuff like that, but on this insurance side, this document sounds like it's great. What is it called, Lisa?
Evaluating a dental benefit plan checklist.
Perfect.
And if they have
Evaluating
any
a dental
questions, they
benefit
can
checklist.
email me and I can send over the link to them.
Beautiful,
But yeah, that
beautiful.
that truly goes through all of the steps that they need to think about before they're looking at contracting with a plan.
So let's say someone decides to go ahead and contract with a plan. There's all this noise out there that the doctors have no power when trying to negotiate with the insurance company. Like, what is your understanding of that? Is it realistic that they can negotiate with the insurance companies on either fees or some of these other terms that you were mentioning, or do they not really have much power?
Terms of the contracts, it's pretty much a take it or leave it kind of a situation.
Okay.
So if you're signing that contract, you're agreeing to those terms that are in that contract. With the fee schedules, and even as an office is in network with a plan and they're looking at negotiating their fees, it's truly about your negotiating power. You as an attorney know that, right?
Yeah,
So
right.
we right? And so we think about with the negotiation power, what's your demographic? Are you in an area where there's a high concentration of dentists that take that same plan? Your chances of negotiating a higher fee schedule is probably a little bit lower. Um, Humboldt County, they have a very small number of dentists. Are dental insurance plans more willing to negotiate with those dentists up there? Maybe,
Mm,
maybe it just really
mhm.
depends. We also encourage dentists too when they're looking at their negotiating. If you have a large employer group that's faithful to your practice, say you work, 5 minutes down the road and you have a large number of employees coming in from Google or Intel or a large employer group like that, that's a little bit of negotiation power also too, because the dental plans want to keep their customers, which is the employers, happy. So if you've got a large employee base that's coming to see you and they're faithful, that's a little bit more reason for the plans to negotiate.
Yeah. And do you recommend that the doctors go at it themselves? They call the insurance companies and try to negotiate it, or do you advise them to go through like a third party? Because there are some consultants and some other groups out there that do it.
Yeah, there's a lot of groups out there that do it. We don't have an endorsed relationship with any of them, but we've vetted a few of them. But it truly just depends, and I can kind of feel out, gauge the audience when a member dentist calls in. If they're just exhausted and confused and
Yeah.
just not wanting to do this, it's like, okay, then let me send you some references and maybe some resources to look at having someone else do it for you. But they absolutely can do it themselves.
Yeah.
Um,
I feel like a lot of people when they end up calling me, and I don't know if it's the same with you, they usually are at that point where they're just frustrated, right?
they're
Or
here. Yeah.
yeah, exactly, or they finally, like, are looking at their numbers with their CPA, and by the way, this is another reason why it's super important to get a CPA with healthcare experience, because they can look at these numbers
Absolutely.
and tell you kind of where you are with things. But usually they find out, man, some people like may lose money on their plans because they're paying their hygienist or whomever more than they're even getting reimbursed, and so they're usually just really frustrated and don't even want to talk to the insurance companies.
Yeah,
So
we've heard that a lot since COVID, especially the cost of having a hygienist in the practice.
yeah,
Those wages have gone up significantly. I'm sure you're aware of that also too.
yeah,
And so there's definitely that. I get a lot of those calls where it's like the fee that I'm getting for a pro fee isn't covering the cost to have my hygienist do the pro
right,
fee.
right,
So
right.
it's absolute frustration. And it's definitely a lot of those conversations are very emotionally driven, and we have to kind of talk them off the ledge a little bit and look at it from the perspective of, okay, let's talk about this, like the dollars and cents part of it, and take the emotion out of it.
Yeah, that's right. That's right. Now, in your experience, when someone is opening up a new office, do you see them either accepting like multiple PPO plans, or do they accept just one, for example, or two? Like, where do they fall?
We really kind of talk to them. Again, it's about how busy that they want to be. And also, the more plans that you're contracted with, you have to have a good insurance biller and a coordinator that can handle some of the insurances. So we recommend, start out with a few of them, but it really just depends on some of those practices when they're starting up. They're looking at getting in a lot of patients quickly. And so they start to contract with more plans. But uh, fantastic story. When I first started with CDA, I had a dentist reach out, and she was going from opening, she was working at a DSO, and she was opening up her own practice, and she was looking at like an opening date in a month. And she said, I've been contacted by this company out of Florida and they want to contract me with these plans. And I was like, okay. So she sent me the list of plans that they wanted to
You're
contract her with.
right.
But once I dug into it, with the least networks, it was like 35 different plans that she was going to be in network with. And so at that point, I was like, do you have a really good experienced biller? And she said, no, I haven't hired anybody yet. And I was like, you might want to wait, like back off, like maybe start with 5 of these,
Right.
30 plus plans and
Yeah.
and kind of go from there.
Yeah, I've had some horror stories where it hasn't happened actually here in California, but a lot of folks that we talk to around the country, for some reason, like the associates get signed up for all these insurance plans, like you were talking about, and then once they leave, because they're just employees, right? So they come and go, change jobs. The practices the doctors have found were continuing to bill
My
under
gosh.
their credentials even after they had left, and it was really kind of crazy because they would suddenly open their own office or something, and then they would get a random check because the insurance company suddenly had two addresses. Like it was like it's been really a mess, and we'll talk about transitions in a little bit. But yeah, it's signing up for every plan under the sun is not necessarily a great idea. Yeah,
Yeah, definitely.
there's actually one consultant that we know of who advises that. They say to sign up, all their startup doctors to sign up basically with everything under the sun, and then they tell them after that you've grown to start cutting back and
Weaning 'em down.
dropping the insurance companies. But we had a client call us actually just a couple of weeks ago, and they were saying that their revenue when they started doing that fell 75% because they had upset so many of those patients who,
Yeah.
were like just, beside themselves that they had come there for a couple of years because it was a new office, and then suddenly they were being dropped,
Yeah. Yeah.
so
The
it
other
can be
thing
bad.
too, when you're signing on with that many plans, we mentioned a little bit earlier, is the payment processing guidelines are completely different for every single plan. So knowing that this plan will cover this and this plan won't, and this plan will only cover it if the the pocket depths are this, it makes it tough when you're contracting with so many different plans to know all the processing guidelines.
Yeah, that's right. That's right. So let's talk about dropping plans because that's been very common thing, in the last couple of years. We're seeing more and more practices kind of pushing back against, against the insurance companies and going insurance independent, especially in the suburbs. Since COVID, like you said, so many patients left the bigger cities and they went to
Yeah.
the suburbs. A lot of these suburban towns have practices that just ballooned, and now they don't have time to see all their patients, so they're dropping
The
the
plans.
insurance
Yeah.
plans. Yeah.
Mhm.
So I'm sure you get these questions a lot, but what should a dentist analyze before dropping a plan? Like, what are some of the basic things that you would say at least start here before you even think about doing it?
You want to look at your patient base from that plan. Like, what is your existing patient base? Do you have 10 patients or families that are coming in that are on that plan? I mean, chances are you can drop that plan with little little to no, problems with it. But you really start with the patient base, look at the fee schedule versus your UCRs, and then look at your top 20 to 25 codes that you're billing out. Don't look at every single one,
Hmm.
and just kind of analyze. And I lose a lot of members when we talk about dropping a plan. We know there's going to be attrition. There's going to be patients that leave the practice, right? But you have to think that the patients that do stay with the practice, you're going to be compensated more for. So there is a break even period in there somewhere. But yeah, truly look at the number of patients that you have coming in that are on that plan, the number of new patients that you're getting from that plan, if any, and then look at their treatment acceptance. Do you have a lot of patients that aren't accepting treatment?
Dude, I love that. I love that. And it's funny, up until about a couple months ago, gosh, when was it? Actually, it was probably November of last year. Of 2025. We up to that point, Lisa, didn't have one client, not one, and we've had hundreds drop insurances and go insurance independent. We didn't have one that was less profitable after than before. So they all made more money after dropping insurances. In November, we had our first that actually was worse off after having dropped it. And that was because they went and did it themselves without professional help. So they didn't really look at some of the data that you're talking about. They didn't use a consultant to walk them through that whole process.
Yeah.
So yeah,
There's
that was
there's
a little
also
sad.
there's a right way to go out of network with a plan and a wrong way to go out of network with a plan. And the right way is talking to your patients long before they get a letter from the dental plan saying that you've gone out of network with them. The
Right.
wrong way is the patient, the first time they hear that you're out of network with them is when they receive a letter from their plan, and you're no longer in network, and then what do? They call the plan to find out who is in network
Right. Exactly.
versus
Exactly.
yeah.
Yeah. Yeah. And some of those letters, we won't name names, but some of those letters that are going out by these insurance companies are
Yeah.
really nasty. I
Yeah,
mean,
they are. They are,
they
yeah.
are
Yeah.
really nasty. I know you may not be able to say that, but I'm going to say it
Well,
because
you have to think about it from the insurance company. Their job is to point patients to in-network providers. It's
yeah.
that
Yeah.
cost containment for the employers, and so their job is to push patients towards an in-network provider.
Yeah, that's right. That's right.
Yeah.
So misconceptions from dropping insurances, like, or going out of network, like, what is some of the bigger misconceptions that you've seen that people come to you with about going out of network?
I'm going to lose every single patient. I'm going to lose every single
Yeah,
patient from that plan, and
yeah,
that's not necessarily the case.
yeah, yeah.
Um, Anecdotally, we hear that you lose the patients that are the great families that bring you in cookies and are always on time for their appointments, but yet from that plan, you'll retain the patients that are late all the time, that are the difficult patients to work with, and so
Yeah,
yeah. But yeah,
yeah.
that's probably the number one misconception is that I can't go out of network with that plan because I'm going to lose all of my patients.
Yeah, that's right. Yeah, yeah. I think a really good friend of CDA, Dr. Michael Perry, who does a lot of this, in terms of going out of network. He tells me the same thing. He says, whenever I look at a practice, and he's, as you know, he's very honest about it. Some
Mhm.
practices are good to go out of network, and some are not. But he says the number one fear is exactly what you just said, that I'm going to lose every patient and I'm going to go out of business and whatnot. And the reality, that's not always the case. Actually, it's
No.
except for that one client in our experience, it has, everyone's been better off. All right, let's shift gears a little bit and talk about claims, delays, and the administrative sort of burden that comes with that. Okay. So do you know what the most common reason is for an insurance company to either deny or delay a claim that's been submitted?
Yeah. So with denials, it's typically they're denying it based off of the payment processing guidelines that the office
Oh,
isn't aware of. Yeah. So
okay.
it's that's typically what they're getting the denials off of. Occasionally, we'll see a denial where the patient wasn't effective during they were effective at the time of treatment, or they didn't have the eligibility at the time of treatment. The treatment was done, but the patient had terminated prior to that. So yeah, definitely payment processing guidelines and some eligibility issues. Frequencies, not so much, but for yeah, claim denials, it's usually that. For claims that are pended, it's most likely the documentation wasn't sent in correctly. So just like every plan has their payment processing guidelines of how they're going to pay and what they're going to pay for, they all have what documentation is needed. And one plan might need this piece of documentation where another plan might not need it. So looking at all the plans is the same and sending in the exact same information every single time, that necessarily isn't going to get you a claim paid any faster. It could get it pended quite quickly. So yeah, lack of documentation.
Okay, so I was going to ask, my next question was going to be like, what can they do to, like, what best practices can they implement to reduce those claims? But it sounds like your answer would be just get really knowledgeable about the plan that you've signed up for, so that you know what to submit and how to submit and what's covered and what's not covered.
Yeah, not only just your insurance biller, but your entire office. And so when you think about even a general dental office, they have 25 to 30 procedures that they do
Yeah.
on a regular basis. So I know that if I am doing a crown, I'm doing a crown prep, I'm going to need a pre-op, x-ray, potentially a photo. Photos are fantastic, intraoral photos are fantastic, but also send a cementation x-ray in also too. Send an x-ray in where it shows the crown is cemented, the margins are sealed, there's no extra cement anywhere. And so having that information and then having the entire office on board and knowing it, like I as an assistant know when I exit this patient, I'm going to snap a quick x-ray and make sure that the crown is seated correctly and everything's fine. You don't need to know the payment processing guidelines for every single procedure, but make a spreadsheet. So this dental plan requires this, this, and that for a crown. This plan requires something different. And so kind of have some cheat sheets together and some easy reference guides and have the entire office on board for it and understand why the need for it.
I guarantee you, someone who's listening is thinking, how am I supposed to do that? I don't even know myself. I'm the doctor. Like, how do I know all these things? So how do they even start that? Like, how do they even train their team on that? To walk us through that. Like, what do you recommend?
We recommend as an office, if you start to see claims that are getting denied for the same things, that's where you want to kind of sit as an office and decide like what's the reason this crown is being denied or this claim is
Mm,
being denied and what can we as a team figure out to do? I mean, are there offices out there that run completely smooth and everything is fine and their claim denials are very minimal? Absolutely. But if there's offices that are out there and you're starting to see claims being denied for the exact same thing, it's time to sit down as a team and come up with a game plan of how to fix it and correct it.
yeah, and I do want to say this. Bringing that up, actually, I think a lot of doctors use these, revenue management companies and whatnot to kind of take that load off of their current team.
Mhm.
And um, sometimes those companies are not doing everything that they need to be doing. And then what ends up happening is that these denials and delays go up, but they sometimes are not informing the practice, right? And
Yeah.
that's
Yep.
impacting the numbers. So if anyone's listening, if you're going down that road and you're going to use a third party, make sure that you're getting reports, I don't know, weekly, bi-weekly.
Reporting back. Yeah, they should
Yeah,
be. Yeah.
yeah,
Yeah.
exactly. And checking, having someone absolutely not take it for granted that it's being done, just making sure that it's being checked. Because if you're not checking it, there could be claims out there that are never processed and nobody's going to talk about it.
And they
So
eventually just get written off because it's been too long and it's
that's right.
past the yeah, yeah.
Yeah.
I always think about as well so too is diagnostic quality x-rays. There's so many x-rays that get submitted to dental plans that are not diagnostic quality. And so the
Right.
plan can only look at what you're sending in. And if you're sending in something with a cone cut or it's the wrong tooth,
Yeah.
they can't approve a claim off of
They
that.
can. Yeah.
Yeah.
Now, can you explain to us what down coding is? Have you heard that term?
Absolutely, yeah. So the most common that we see and we talk about is the non-covered services law as well, so too. So
Okay.
downcoding would be most common we see with implants is say an implant isn't a covered benefit on a plan, but what is a covered benefit on the plan is the replacement of the tooth. At the lowest point, a partial denture maybe or a
Mhm.
bridge. It just depends on how the policy is
Okay.
written.
Yeah.
So the plans will downgrade or downcode and pay at the partial or bridge rate, and then the patient is responsible for the difference. So we see that a lot with implants, and we see a lot of that with composite fillings on posterior teeth, so the tooth-colored fillings on the
Hmm.
back teeth.
Hmm.
The plan, if composite fillings aren't a covered benefit, a filling is the covered benefit, and it's the amalgam. So the plan will downgrade and pay at the amalgam rate, and then the patient is responsible for the difference. So they get a little bit of a prorated fee.
Got it. And do
Yeah,
patients, I mean, is this something that the office should be telling patients beforehand? Hey, this is not covered and you'll be
absolutely.
responsible for the difference? Yeah.
Yeah,
Yeah. Yeah.
yeah, that's
Yeah.
that's something that's part of a really comprehensive benefit breakdown when you first see that patient in the practice,
Yeah.
or if a patient comes in and they have a new plan, getting all of that information and knowing like composites aren't covered on these, or porcelain crowns aren't covered on these teeth, things like that.
Yeah, I had a conversation from someone from the dental board who said, to ask me to bring this up. This is a few years ago now, but asked me to bring this up during my California Practice Act lecture. He's like, because we're getting a lot of complaints from patients regarding this, that the office didn't tell me and they're, kind of bait and switching me and all this. And as you know, the dental board doesn't get into fee
They
disputes,
don't,
but
they sure
but
don't,
they
yeah.
but they still have to deal with these, things that come through. And so they wanted us to talk about it. So okay, all right, perfect. All right, let's talk a little bit about trends that you're seeing out there. So obviously, CDA is at the forefront of this. They're very, very active, with regard to all of the, everything having to do with, the third party payers, whatnot. What are you seeing insurance companies are doing in terms of changing their reimbursement models, if at all?
We don't see them changing the reimbursement models. I mean, they're changing and making more procedures inclusive here and there. They do evaluate and look at the market and adjust fee schedules periodically. We obviously don't feel like it happens enough because they're not really
Right,
keeping up with the cost of living.
right,
And I don't think you can get out of anything without saying AI at this
right,
point in time.
right,
AI is just the dental benefit plan industry has been using AI for scanning claims for years, but now what they're using it for is so much grander, so much
right,
broader. So
right,
we're
right.
seeing, I mean, we don't have a meeting at CDA that doesn't involve AI at some point in time.
Yeah,
Like
of
we're
course.
always talking about it.
Yeah. And are you seeing like larger groups or DSOs helping influence these insurance carriers, like helping increase the reimbursement rates as they negotiate theirs? Or is it sort of case by case and they're not really having an impact on the overall kind of rates that your mom and pop general dentist is getting?
Yeah, I think it's more of a case by case situation
Yeah.
that's yeah, yeah.
Yeah. Yeah, because we keep hearing doctors at these study clubs say, "Oh, I heard this group negotiated with so and so insurance company," and then we find out that doctor is part of like a larger affiliated,
Yeah.
DSO or
Yeah.
whatnot, and so it's very unique. Yeah, yeah.
And then
Okay.
it teeters on it again, it teeters on that the antitrust also too. So, you can't get a pact of dentists together to try to negotiate those fees. So yeah,
Right,
it
exactly.
does teeter on that. Yeah.
Yeah. Okay, so if you're looking at your crystal ball, and what do you see in the next 5 to 10 years? What should a dentist do to prepare when if they want to stay in network, or I guess maybe I make it more broader. Like, what do you see happening into the insurance world in the next 5 to 10 years? And do you see more people dropping it and going insurance independent, staying in because rates are going up? Like, what do you foresee?
I foresee that more offices are going to be going out of network simply for the fact that the fees aren't keeping up with the cost of living here in California for
Yeah.
sure.
Yeah.
So I think it's getting tougher to do business here in California for dentists. I would love to see from a selfish perspective, I would love to see the documentation that offices are having and taking that information. Like just be so much better with your documentation because that will save you so many problems down the road.
Right.
So selfishly, that's what I would like to see in the next 5 years is just increase your documentation, x-rays, intraorals, and things like that. But no, I truly, I feel like there's going to be a little bit more of an outer network, another wave. I don't think we've seen the last of it by any means. And I think patients are hearing enough about it now that they're understanding it a little
Yeah.
bit better.
Yeah.
Yeah.
Yeah. I agree. I think the education level of patients has gone up.
Yes. Yeah.
where
Yeah.
where they understand the impact, and if they love a practice, if they love the experience they're getting, they're willing to pay a little bit out of pocket, because public enemy number one is still the insurance companies, and they know the doctors have their hands kind of tied in certain situations, and I think you raise a really great point, because with wage inflation the way it is, and it's not just with hygienists. I mean, it's everybody, down the line. It's just expensive. It's just expensive. I feel like the only area in California, and I know this is not true necessarily around the country, but I feel like the only area in California that's been sort of protected against wage inflation at the same rate as the rest of California is the San Diego market, which is really odd, right? Because
Interesting.
it's
Yeah.
it's it's such a great market for dentistry, and there's so much wealth, and there's so much business and whatnot there. But I don't see the wages there being anywhere close to Orange, LA County, any of the Bay Area, Northern California counties. Like it's sort of an anomaly, which is weird. But I think this is the case around the country too. Like Seattle, Washington has a lot of wage inflation, like that whole Tacoma, Seattle area. But you go to
Yeah.
Eastern Washington and it's like not at all, right?
Yeah. Yeah.
Same thing with, other parts of the country. So,
It's that
okay.
supply and demand. Who doesn't want to live in San Diego, right?
Yeah, that's
The
right.
weather's
That's right. That's
beautiful.
right.
Yeah.
There's
Yeah.
that too.
Yeah.
There's that too. Yeah.
I think if
Um,
you can't control your wage, there's things as an owner dentist that you can't control. Wages to some extent are a little bit out of your control. The fee schedules, the plans sometimes are out of control, but your supply costs are well within your control. And I think that's another route to look at as if you're looking at kind of controlling costs and evening things out a little bit is look at your supply costs.
Yeah, that's right. That's right. Yeah, and there's a lot of great companies out there now that are really pushing those costs down, from the traditional, wholesalers and distributors that are out there. So you're
Yeah.
exactly right.
Yeah.
All right, let's shift gears to some more controversial things that happen every day, right?
Okay.
Having to do with practice transitions. Okay. So I know you know this, but I'll set the stage for our audience. So when a doctor is buying a practice, if the seller is credentialed with an insurance company, usually there is a period of time between, from when the practice is sold, right, to when the buyer becomes credentialed, that there's ambiguity about who can do what.
Yes.
And
Yeah.
so what I see, every single day is that the buyers end up uh, uh, billing under the seller's credentials as the treating doctor, meaning the buyer ends up putting themselves down as the treating doctor, but they're putting the sellers down, or it's under the seller's credentials. And we all know that's not technically correct.
Yes. We like to call
So
that improper billing.
improper billing, yes.
Yeah.
But it seems like the insurance companies, knowing how slow they are to get people credentialed, are kind of maybe looking the other way. And I don't know if that's accurate or not, but I'd love to get your thoughts on this, because because it's a really, really difficult, you know, transition. It's a really difficult moment.
It is, yeah. Where we see this become an huge issue, and I had a conversation with a member today, but where we see the huge issue is when plans go in and do audits, and the name that's on the patient's chart and their treatment plan doesn't match the name that was submitted on the claim form. And if there's a
Right.
difference of fees in that, then it's going to be a significant recoupment amount that's going to come back. I just talked to an office today that exact situation happened. They were billing under the seller's information while the buyer was getting credentialed with the plan. That was a period of a couple of months.
Yeah.
Well, in that time period, the purchasing dentist had prepped a crown for a patient, and that patient didn't end up coming back for 2 years. So the patient requested a refund. Well, now they're sending money back to the dental plan and having to tell the dental plan that, oh, by the way, this was billed under the wrong provider. So it creates so much havoc. It just creates huge problems down the line for
So
everyone.
what's the solution, Lisa? Like what is the solution here? Because, I've seen it take 3, 4, 5 months sometimes to get credentialed, right? It's gotten a little bit better actually in the last
Yeah,
couple of years, but
yeah.
before that it was like really long. Like what do you see, like what should a buyer do? Like what is the best practice, the realistic best practice?
Have all of your documentation together from the jump. Get that packet, reach out. So there's a period of time between when I make the offer to purchase the practice and when the escrow closes for the practice. So during that time period, reach out to the plan. Of course, you sign everything ahead of time and then date it for the day that the escrow closes on the practice. That's one thing. But have everything together and ready to go day
Mhm.
one. Also, squeaky wheel gets oiled. Reach back out to the practice and or to the plan and say like, hey, why is this taking so long to get credentialed, and what's kind of the holdup? The plans want a provider network. They want to have a really robust provider network because they want to be able to report back to the regulators, look at how great my provider network is. And that is also a selling tactic for them as well. So too, when they're going to employers, we have this huge provider network. They want providers. They want contracted providers. So yeah, continue to reach out to them. Have all of your ducks in a row from the beginning, and continue to reach out to them and push them and see.
So you're saying get your applications, get your paperwork, get everything ready to submit. As soon as you buy the practice, submit all that either yourself or through, a third party. And then just, you know, um maybe delay the transition or like I mean, do they I mean, what should they do if I mean, do they delay it until they get credentialed and then buy the practice? Like what would
They could, but that could tank the sale of a practice depending on what the terms of the
Exactly.
practice are. How quick does that selling dentist want to get out? I mean,
Exactly.
billing as an out-of-network provider is billing as an out-of-network provider. It is what it is. I mean, there's a few plans that cause a little bit of a hiccup as far as payment goes when it's an out-of-network provider. But what's to say 30 days to bill as an out-of-network provider? How big of an impact is it going to have? Mm, not that's something you have to kind of look at.
And when you say bill as an out-of-network provider, that means that the checks go to the patient. Is that
Not all
right?
plans, not all
Oh, not all
plans.
plans.
Yeah,
Oh,
not all
okay.
plans. Yeah, yeah,
Okay.
not all
Okay.
plans have not all plans have a no assignment of benefits for an out-of-network provider. So we're
Got it.
talking about assignment of benefits.
Yeah.
The majority of plans will allow assignment of benefits. There are some that are very strict that it's
Okay.
automatically going to go to the patient.
Got it. Got it. Can you tell us which one those are currently or no? Is it
As far as Delta is the one that the majority of their policies have no out of network benefit or no assignment of benefits for out of network providers. So
Delta?
Delta is
Okay.
the number one. The
Okay.
rest of them, it's a small percentage, but it can come up, and you find out the wrong way when the check goes to the patient.
Yeah, yeah, exactly. Yeah,
Yeah,
okay.
yeah, yeah.
Okay.
So
And
just
and
knowing that going into it ahead of time, if you're contracting with Delta or you're seeing Delta patients as an out of network provider, you're going to want to make other arrangements with the patients as far as collecting in full upfront. They'll get the check later down the road.
Okay. And there's no other strategies, nothing else that you've seen that works during that transition period that would be kosher, that would pass, compliance and all of that during this transition period while we wait for the buyer to get credentialed.
No, we've heard it from so many different it's been presented so many different ways. Well, there's a supervising dentist, or there's, even in your contract for selling the practice, it's written into the contract that you will allow them to use your information to bill
Yeah,
for a set period of time. One contract doesn't negate the other one. We've looked into that. The other thing too is that I've talked to dentists and member dentists that have gone through that, where they have had it in their contract that the purchasing dentist can use their information to bill for a set period of time. Well, that continued on
right,
long after that
right,
selling dentist was out of the practice and retired, and finding out at tax time that they're getting 1099s from the plans with monies that have been paid towards them that they've
right.
never received. So
They've never
then it
received.
becomes that whole other issue of situation of taxes and CPAs come in and all of that. So
Yeah, yeah. No,
it's
that ends
never
up becoming.
advisable. Yeah, it's never advisable. It's a hiccup along the way. It's definitely
Yeah.
a hiccup along the way.
Yeah, yeah, yeah. It's all about, I think, risk tolerance, right? Like how much risk does a seller and buyer, how much are they willing to take? And even though I think the insurance companies do realize this and they are looking the other way, like you mentioned, there's so many problems that can come up, especially with refunds and or audits and things of that nature, that it can open up a can of worms for sure. So
Plans have the ability to run claim reports and find all of that information out. Do they do it on a regular basis? That I don't know.
yeah,
I
yeah,
see it come up in audits is
yeah.
when the huge issue comes up is with audits.
Yeah, that's when we see it too. Yeah, it's
Yeah.
only during audits that there, it really becomes an issue. So, okay. So let's talk a little bit about NPI ones and NPI twos, because there's a lot of information out there about that kind of can be confusing, right?
Well,
So,
sure.
so can you walk us through, for those that don't know? I mean, most providers already have their NPI one, but can you talk about what the difference is between an NPI one and an NPI two?
Sure. NPI 1 is an individual provider's NPI. So I always equate it to, it's your dental license. You're going to take that NPI 1 with you no matter where you go. But you can have several NPI 2s. That's a business. So if you owned several different practices and had several different NPI 2s, that's great. But you're always only going to have one NPI 1. That's your individual NPI 1.
Okay.
Yeah.
And why would someone want to have multiple NPI2s for each of their offices versus just keeping it with their NPI one? What are the advantages or
That I don't know.
disadvantages?
That's a CPA question. I have no idea. I don't know if they have different businesses set up under different, maybe there's different owner dentists in, maybe there's
Okay.
co-owners of one and an individual owner of one. Yeah, I don't know. Yeah.
Okay. But if they have multiple corporations or multiple offices, they don't need to have an NPI2 for each one of them, right? They can just keep the NPI one. Is there anything with the plans that makes it more advantageous to have different NPIs there?
Nope. Nope.
No? Okay.
No. Yeah.
Okay.
The plans look at it just as that provider number.
Okay, okay.
Yeah.
What if they have NPI twos and then a buyer acquires the practice? Do they acquire that plan with that NPI two since it's
Nope.
not tied to the
The
seller?
the yep, nope. The new yeah. The new owner would have their own NPI 2.
But they
That
would have to get
NPI
a
2
new
doesn't
NPI two.
follow, yeah, it doesn't
Okay.
follow the business. Yeah.
Okay. Okay. Yeah. Yeah. I heard a consultant one time say that it was something that was inheritable by the buyer, and it didn't seem right. But there's a little bit of information out there
Yeah.
about that. So no. Okay.
Yeah. And why wouldn't you have your own NPI 2? I mean, you just create a new NPI 2, you apply for new NPI 2.
Right.
It's not, yeah.
Yeah. Yeah. Okay. Perfect. Um, All right. As far as, and this is my last question as far as acquisitions go, but if someone's buying a practice, is there anything that they need to like look into or do in terms of their due diligence with insurance companies, or insurance contracts when they're looking to buy an office? What would you have a buyer look at?
I would have the buyer look at what plans that the seller is contracted with,
Okay.
and then contact those plans and take a look at the fee schedule that's being offered currently for that purchasing dentist,
Okay.
and take a look at it and see if it's something that's comparable to what they're receiving now, because you don't want to see that the practice has been valued at a fee schedule that purchasing dentist can't get, can never
Right.
touch.
Right.
So I would take a look at that first, and then also to look at your contracts. Take a look at your dental plan contract. So when you're signing a new contract, read through it. Give it a look over. Send it over to us. We can send the evaluation over to ADA for the analysis of the dental plan contract. But look at what you're really signing with those plans.
Nice. Yeah.
Yeah.
And do you ever see like do you ever see those reimbursement rates and those terms of the old plans being kind of transferred to the buyer with a new, when the buyer comes in, when they sign up, or is there always a new fee schedule?
Uh, no, it's not always a new fee schedule. It depends on how long that selling provider had that fee schedule, how active they were with asking for increases
I
and
see.
trying to negotiate a higher fee schedule. But yeah, and also we think about it too as when I started my practice, if I opened up and there were 5 dentists within a 20-mile radius, I might have a higher fee schedule than what's being offered now
Right.
because it's saturated. There's many more dentists in the
Many
area.
more
So,
dentists. Okay.
yeah,
Okay.
yeah,
That makes sense. Okay. Wow.
yeah.
Okay. Well, great. Well, thank you, Lisa. That was
Of
amazing.
course, yeah.
Okay. We've got a couple of questions that were submitted
Okay,
to us. So I'd like to ask you these questions, even though they're asking me.
perfect.
um,
Yeah,
okay. So the first question is, Ali, almost all of the dentists in my area have gone insurance independent, and so I'm getting a lot of patients, but I can't handle the volume. What do I need to think about before I decide whether to drop all the third-party payers in my practice? I mean, we talked about this a little bit actually in the beginning, but maybe Lisa, give them like three things to look at before they decide what to do. Yeah.
go back to your business model. Is this an opportunity for you to bring on an associate part-time and maybe start to increase your production and have an associate there taking on some of those patients? So go back to the business model, potentially adding on a provider or even adding on another hygienist to help with those patients. You can close yourself off to new patients with the plans. You can't pick and cherry pick on it. So if you're closing yourself off to all PPOs, you're closing yourself off to all PPOs. You're basically saying, I can't serve the patients that I have currently. So that is an opportunity, but I would look at a growth, like look at as an opportunity for growth versus, shutting the doors a little bit.
Yeah, I love that answer. I love the answer. And I think too, if you're in that position and you're listening today, looking at the business plan that Lisa said, I think is really vital because depending on where you are in your career, you could be at a stage where where you think, you know what, I can go maybe buy a building or buy a condo or move to a bigger location and expand my practice even further because I don't have room right now, but if I build something out, then I'll have more capacity to see these patients. Or depending on where you are in your career, you might say, you know what, enough is enough, right? I want to slow down. Maybe, like you said, Lisa, you bring in an associate. So it's really looking more introspectively about the plan and what you want for the future. Because hiring an associate is not for everybody. Although, bringing on an associate or a hygienist can definitely help with capacity.
Benefit for sure. Yeah.
So
Do I
yeah.
want to cut my days 1 day a week to be able to bring an associate in 2 days a week? Is that my long-term plan? Is that I want to start to whittle my days down and turn it over to somebody else? That's yeah,
Yeah. Yeah. I Dr. Natasha Lee, of course, and
absolutely. Yeah.
she teaches this incredible class at UOP where she puts her students, the entire graduating class goes through, I think it's like a 5-month program or maybe a little bit longer, where they go through an entire kind of business simulation. And we just had the session where the us bankers, if you will, are there and we ask them questions about their experience through the whole simulation. And they have options when they go through the simulation to draw plans and add chairs and all of this. And it was fascinating the response that they got depending on the business decisions that they made. So some
Got it.
people
Yeah.
like
Yeah.
some people dropped, their plans but didn't increase marketing, and then so their revenues went down. Or
Yeah.
some
Yeah.
people like added an extra hygienist and then their revenues grew greatly, but they never dropped the plan. There was all these different options. And so I think, to your point, what's important is figuring out what the business plan is and then staying true to that,
Absolutely.
if
Yeah.
you're in this position. So yeah, that's great. Okay, the next question is, Ali, I recently looked at one of our insurance fee schedules and realized we're getting paid almost the same as we were almost 10 years ago, but our costs have increased dramatically. What options do I have?
So, I would first start with negotiation. That's the first process. You want to look at that. See if you can increase those fee schedules. Don't look at increasing all of the fees on your fee schedule. Again, look at those top 20 to 25 codes that you're billing out as a regular basis. Start with those and see if there's any kind of negotiation room in that. And then wait for the plan to respond. So, sometimes the plan will come back and they'll give you, maybe $1 increase on a couple of procedures here and there. Then kind of look at the fact of like, okay, is this sustainable for this dollar increase? Or sometimes the plans will increase on a procedure that you don't do very often. And so it's like you have to kind of think about it that way. But first, try in the negotiation first and foremost. From that point on, then start to do the evaluation of how that plan is producing in your practice, how it looks, the number of patients that you have on that plan, the treatment acceptance, the collections you're getting from it, and just kind of make the educated decision there whether to remain in network with a plan or if you decide to go out of network with a plan. But start with the negotiation first.
Yeah, that's great advice. And for those of you listening, if you don't feel up to it and don't want to do it yourself, there are a handful of really good companies that can do this for you. They're not all great, actually.
Yeah.
So
Yeah.
call Lisa, call us, and we can give you a couple names, and then you can interview them and see if it's a good fit for you. The other thing I would mention as we end today is I think there's this belief that insurance companies just will never negotiate because they've never negotiated. But we're seeing the tide turn, right? And like you said, depending on your location, depending on kind of what practice you have, depending on what you're doing, some of them will negotiate with you. So just because your friend, in downtown San Francisco didn't negotiate, doesn't mean that if you're in Los Angeles or San Diego or Sacramento or wherever, that they won't negotiate with you. So just keep that in mind, everyone.
Yeah. Yeah.
There's
Absolutely. Yeah.
so anyways, well, Lisa, thank you so much for
Thank
being
you.
here and sharing your incredible insight. You're a true expert in this, and so CDA is lucky to have you, and we, I think, are all lucky to have CDAs kind of supporting and advocating for dentists. I know it's not easy to represent so many dentists, statewide, but you guys do a great job, and you're always fighting for dentists and those that support dentists. So thank you
Yeah.
for that.
I absolutely love my job. I couldn't it's fantastic that I get to talk to members on a daily basis and help them and go through some of their trials and tribulations of everything they're going through. But it's the number one thing that I get to do every day is educate on one realm or another. And it's fantastic. I absolutely love my job and so grateful to be here and serve our members.
Well, thank you for everything you do. Thank you.
Thank you. Thank
All
you.
right, everyone. Thank you, everyone. If you like this episode, please comment, like, and subscribe to Ali Off the Record, and we'll see you next time. Bye, everyone.